Okay. So, continuing on through the respiratory system, respiratory tract, I should say. So we've discussed the larynx. Now we'll continue down into the next structure, which is called the trachea. So the trachea is basically the airway that leads down to the lungs. Again, only air should ever pass through the trachea. So the trachea lies directly anterior to the esophagus. So here's the esophagus. Here's the trachea. It's a tube, and it's supported structurally by rings of cartilage, but they're C-shaped. They're not complete. So you can see here in a cross section, esophagus, trachea. Here's cartilage, and it's sort of C-shaped. Doesn't go all the way around. Basically, the reason it doesn't go all the way around is because of the attachment of the trachea to the esophagus, so that the cartilages end at that point of attachment. So trachea, is the lumen where the air passes through. Let's look at the epithelium that lines basically the lumen of the trachea. So you can see it here. So the epithelium that lines the lumen of the trachea is a type that you may remember from ANP1 called pseudostratified columnar epithelium. Pseudostratified just means that it is sort of more than one layer, but not really. All the cells are attached to the basement membrane down here. It doesn't really matter. By the way, this is the lumen. This is the apical side of the epithelium. Here's the basal side and the basement membrane, and then here's the connective tissue beneath. This is a histological image, of that tissue. So here's air. This is the apical side of the cells, basal side. There are two features I want to draw your attention to. The first is that in the pseudostratified columnar epithelium, there are a lot of what are called goblet cells. So lots of goblet cells. And if you may recall from ANP1, the role of goblet cells is to produce and secrete mucus. So this stuff here is the mucus that was secreted out by the goblet cells, and it just sort of lines the trachea all up and down. It lines the lumen, the layer of mucus on top of the cells produced by the goblet cells. And that mucus has basically the same kind of function that the mucus in the nose provides, and particularly here, really the main function is to trap inhaled particles. So things that make it past the nose, if they don't get trapped up there, hopefully get trapped in the tracheal mucus before they make it down to the lungs. So the other feature that I want to draw your attention to of this epithelium is that the cells are ciliated. So they have cilia on their surface, and that cilia constantly beats in an upward direction to move the mucus upward. So, being that this is a ANP, especially ANP2, you'll get accustomed to dealing and speaking about the gross things our bodies do. You may have noticed that when you wake up in the morning, you tend to have a lot of yucky stuff in your mouth. That's basically the action of these little cilia moving the mucus up your trachea all night long getting stuff up and out of your trachea to prevent it from getting into the lungs. So doctors have a term to refer to this that they call the mucociliary elevator. The idea is that this is it's the movement, constant upward movement of the mucus due to the action of the cilia, and it traps and eliminates inhaled particles. And one of the things that's sort of notable about that mucociliary elevator is that so smokers, the smoke that they inhale, one of the clear effects that it has on the tissues is that it basically tends to decimate the cilia on these cells. So the mucociliary elevator no longer functions appropriately. Smokers have a much higher amount of their inhaled particles getting into their lungs than a healthy person because of basically the failure of this mucociliary elevator. So not only are they, by smoking, inhaling lots of small particulate nasty things, but they are worse at getting those out than a non-smoker would be. So, in case you never got this message before, don't smoke. Okay. So, next we get to what's called the tracheobronchial tree. So the trachea is the first part of this tree, and it's called a tree because it really kind of structurally looks like a tree, right? So, this is the trachea, branches into smaller tubes called bronchi. Basically, all these tubes in here are called bronchi. So, branches, then more branches, more branches, more branches, smaller and smaller bronchi, bringing air through into every part of the lung. So that's the tracheobronchial tree. Let's kind of we'll follow the branching down to at least a few stages. So, obviously we start with the trachea. The first branching is into what's called the main or primary bronchus. So you have obviously a right and left main bronchus. Next, the main bronchus divides into what are called lobar bronchi. Okay, so this is the main, and then the next division is called the lobar bronchi. So here's a more sort of schematic diagram. So trachea, main bronchus, and then the blue are lobar bronchi. The reason they're called lobar bronchi is because there's one for each lobe of the lung. So this is the right lung, this is the left lung, and the different colors here indicate the different lobes of the lung. So 3 lobes on the right, 2 lobes on the left. So on the right you have 1, 2, 3 lobar bronchi. On the left you have 2 lobar bronchi. They're obviously not colored like that in real life. They look more like. So here's a sort of a slightly more. Well, let's see. There's a good picture of the lungs. Anyway. So 1, 2, 3 lobes over here, 2 lobes over here. So those are the lobar bronchi. Next we get what are called, so in the next branching are these red ones. They're called the segmental bronchi. So, and they serve what are called bronchopulmonary segments. So the bronchopulmonary segments are the ones that are now colored differently in this image. There are 10 on the right and 9, or some people say 10, depending. It's sort of, depending on how exactly you define them. Either 9 or 10 bronchopulmonary segments on the left. And then you can see that there are a corresponding number of branches of the bronchi. So here they have 10 and 10 in this case is how they drew it. So this person apparently is on the side of having 10 on the left, but whatever. So bronchopulmonary, segmental bronchi are the red ones, and each branch corresponds to a different bronchopulmonary segment of the lung. We'll talk about those segments and what they mean when we get to the lung in just a moment. Okay, so these segmental bronchi, these are the last ones that are specifically named in terms of having their branching having a name. So the segmental bronchi are the last ones that are given a name, but there are many more branches. I think there's something like 100 branches from trachea down to the very last branch typically. Most of them, after the segmental are not named, but you get to smaller and smaller bronchi. Eventually we get to what are called bronchioles. Bronchioles are generally defined as having less than 1 millimeter diameter. And then at the very end, you get to what are called terminal bronchioles. So we see that one of those here. And the key idea of the terminal bronchiole is that it's basically where alveoli start to show up. Alveoli are the actual air sacs where gas exchange takes place. And terminal bronchiole are bronchioles where you start to see alveoli, and then they terminate in basically just a whole cluster of alveoli. So there's a key general sort of aspect of the tracheobronchial tree. So up, in the larger components, so trachea, the large bronchi, the tubes are lined with cartilage and they're pretty stiff. Not lined, sorry. They're surrounded by cartilage rings, and they're stiff. They're not really. They can't really change their diameter. But as you start to get down to the smaller bronchioles and terminal bronchioles, you see less and less cartilage, more and more muscle. So smooth muscle lines the smaller bronchi, the bronchioles, and the terminal bronchioles. And the muscles are responsible for changing the diameter of these tubes. So as the muscles contract, the airways constrict, the diameter gets smaller. And as you know, air is just a fluid passing through tubes, and anytime you change the diameter of a tube, you're going to severely affect the flow, right? So we said flow is equal to pressure times diameter to the fourth. So if you narrow the diameter even a little bit, you're going to get a big drop in flow, right? And so that's what these smooth muscles accomplish. If you want to increase or decrease the flow of air, you can do it by changing the smooth muscles. So you'll notice that running along the airways all throughout the lung are nerves. And these nerves include, so it's autonomic neurons, both sympathetic nervous system and parasympathetic nervous system. And let's try to guess. So if sympathetic input is strong, if you're getting a lot of sympathetic input to these smooth muscles, let's think about what do you think what effect that would have on the muscles. So sympathetic nervous system, fight or flight, You see the lion. What do you need to do breathing-wise, right? You're going to start running. You need to breathe more to get more oxygen in. So, sympathetic nervous system leads to dilation of the smooth muscles surrounding airways. Parasympathetic nervous system leads to constriction of the airways. And it turns out that this is pretty important to know clinically. So there's kind of a couple examples I can use. So first of all, anyone who has a kid, especially a young kid, in preschool or daycare these days, knows that there are lots of allergies out there these days. The big one being peanut allergies, and so if a kid has a peanut allergy, adults, of course, this is relevant for them too, but they can usually kind of figure out how to avoid peanuts. Kids have a hard time with that. If a kid has a peanut allergy, say a kid in the preschool class has a peanut allergy, what do you have to keep on hand to make sure that kid, in case that kid ingests some peanut butter accidentally? And so it's what's called an EpiPen. An EpiPen contains basically a big dose of epinephrine. Epinephrine is a strong activator of sympathetic nervous system. So, and what happens is if a kid with peanut allergy ingests a bunch of peanuts, the thing that can really kill them is that for some reason one of the big components of the allergic response is that these smooth muscles in the lungs start to constrict, especially in their trachea. But they get like laryngospasm, really more in the larynx than in the trachea. But you get these constriction all up and down their airways. You need to get these muscles to relax. You give them a big dose of epinephrine through the EpiPen. Activates the smooth muscles. Activates the sympathetic receptors on the smooth muscles, causes them to dilate. Increase the airflow. It's really only a temporary fix. These kids need drugs to block the allergic effect, basically. But the EpiPen will get them to the ER without basically dying of lack of airflow. Another example. So asthma. People who have asthma have sort of hyperreactive smooth muscle. They just have sort of general allergies, often to sort of pollen and that kind of thing. Can also cause that same sort of over constriction of these muscles. And so people who have asthma, when they are undergoing an asthma attack and things start to really get constricted, the drugs that they take an inhaler. So asthma rescue inhaler, so sometimes they take inhalers of anti-allergy drugs and stuff like that. But if they're having severe trouble breathing, they take a rescue inhaler, and the drug is called a beta agonist, which is a sympathetic nervous system activator. So they breathe in this drug that activates the sympathetic receptors, causes the muscles to dilate, and they can breathe better. And here's like an interesting sort of clinical issue. So suppose you're working at a clinic. You're an outpatient doc. Someone comes in and they have really bad hypertension. You've tried some other drugs, some of the mild stuff, and it hasn't really worked. There's a drug that's really effective in reducing blood pressure. So a powerful blood pressure drug, and it's called a beta blocker. So it basically blocks sympathetic nervous system receptors. Okay, so you give someone a beta blocker. So sympathetic activate. So let's think about the sympathetic input to the heart and to the vessels. So sympathetic input to the heart makes the heart have a higher cardiac output. Sympathetic input to the vessels makes the vessels constrict. You block the sympathetic receptors, you're going to make the heart have a lower cardiac output. You're going to make the vessels dilate. It's really quite effective at reducing blood pressure. It has some problems. It's not the first drug you choose, but it's powerful. So let's say this person comes in and they're like, "Doc, I have really bad blood pressure." You say, "All right, we've tried all the other drugs. Let's go for the big guns. Let's give you a beta blocker. Let's block your sympathetic receptors. Bring down your blood pressure." Give that patient a drug. They go home, they take it, and next day they come into the ER because of a severe asthma attack. Well, guess what? This patient was an asthmatic. They have hyperreactive smooth muscle in their lungs. You give them a beta blocker for their blood pressure, you're going to block the sympathetic receptors in their lungs. You're going to let the parasympathetics take over. They're going to get constriction of their airways. They're going to have severe trouble breathing. So this is sort of an example of how, it's really important to understand how, autonomic inputs affect all the different parts of the bodies. Because a lot of times you'll try to treat one thing in one area, but you have to know, try to treat sort of the sympathetic effects that are happening to one system, in this case cardiovascular. You have to know what the sympathetic effects are in the respiratory system, even though that's not what you're trying to treat. Because the side effect of a beta blocker used for heart blood pressure is that it makes the airways constrict. And if that patient's an asthmatic, they're going to be in big trouble. Okay? Okay. All right, so let's now keep proceeding down and actually talking about the lungs themselves. So the lungs, they basically fill up the chest, except for the mediastinum, where you find the heart and the major vessels and the esophagus and trachea. Everything else in the chest, inside the chest, is the lungs. So here are the lungs. These are the lungs viewed medially. So if you took the lungs out and looked at their medial face, you'd see they'd look like this: right lung, left lung. One of the things you notice is that the left lung has kind of a chunk taken out of it. That's because the heart basically sits more to the left of the midline. Let's see if you can't really see, you can't see the heart in this picture, but you can picture the heart being right here. The heart, the bottom part of the heart sits to the left and kind of takes out this chunk of the left lung. That basically notch taken out of the left lung is actually called a cardiac notch. The inferior surface of the lungs actually sits directly on the diaphragm. You can see that here. The lateral surface of the lungs directly touches the chest wall on all sides. The medial surface of the lungs, the main thing to see is that for both lungs you get this area in the middle where all the tubes that go in or out of the lung are found. So all the structures, not just the tubes, actually all structures that go in or out of the lungs are found here at the hilum. So you get pulmonary arteries, pulmonary veins, bronchi, and nerves and lymphatics as well. All pass in and out of the lungs through the hilum. So that's called the hilum. Did I say that already? Yeah, that's the hilum. As we have mentioned, the lungs are divided into lobes. So 1, 2, 3. So 1, 2, 3 lobes on the right, 1, 2 lobes on the left. The lobes of the lungs are separated by they're divided by thick sulci. They're basically very separate from one another. Thick membranes separate the different lobes. And then you can subdivide each lobe into what we call bronchopulmonary segments. So each of these colors here is a different segment. The segments aren't separated by obvious sulci the way the lobes are, but there are actual real pretty significant connective tissue membranes inside the lung that divide the different segments from one another. That's actually important clinically because when people get a pneumonia, the pneumonia is so these connective tissue membranes inside the lung can help basically contain an infection to just one segment. So when people get a pneumonia, typically the pneumonia starts out anyway as being what's called a segmental pneumonia. You can see that. So you can see here in this X-ray, so that this white stuff is basically the fluid of the infection, but it's contained in this area, in this part of the lung, and this is basically one segment, and it can't flow easily to other segments because of the connective tissue membranes. Now some bugs can kind of get through those if you get a bad enough pneumonia, but at least it helps contain it. Okay. Now let's talk finally about the very last part of the respiratory tract, which are the alveoli themselves. So alveoli are the critical part of the respiratory tract, and they're critical in the same way that capillaries are the critical part of the circulatory system, in that this is where gas exchange can take place. It's the only part of the whole tract where the walls are thin enough to allow gas to go back and forth from the air to the fluid and back. Alveoli are densely surrounded by capillaries. So you get the blood coming in through the pulmonary artery. So it's pulmonary artery carrying blood into the lungs. Would it be blue or red? Well, you're carrying it to the lungs, so it probably doesn't have much oxygen. It's blue blood, right? So you carry blue blood in, and then the arterioles, and then basically divide into just like incredibly dense network of capillaries just covering the alveoli. As those capillaries pass across the alveoli, you get air exchanging across the wall of the alveoli into the capillaries, turning the blood from blue to red, right? You're absorbing oxygen as you go, also giving off what? So there's something so oxygen is in low concentration here coming down. What's at high concentration? The answer is, of course, CO2. So lots of CO2. So you come in and then cross the alveoli, give off the CO2 into the air, and then so the blood coming out in pulmonary veins going down back to the heart should have high oxygen, which is why the blood looks red, and then low CO2, right? So let's look at an alveolus in cross section. So here's the airspace. Here's the lining of the alveolus. It's lined by an epithelium, and that epithelium is simple squamous. So simple means a single layer, squamous means thin cells. Why simple squamous? Well, it's the same as it was in the capillaries, right? Simple squamous, thin as possible to maximize the ability for things to pass across them, right? Thinner the membrane, the easier diffusion is. So that's the epithelium lining the alveolus. One thing that's important to know is that here in the basically tissue of the lung surrounding all the alveoli is a bunch of elastic fibers. So the lung has a lot of elastic fibers. It's a very elastic structure. Those elastic fibers have kind of two functions. So the first is that they give the lung recoil. Okay, so breathe in pretty deeply. Kind of hold it for a few seconds. As you were holding it, you may have noticed that you were doing work. It takes effort to hold air in. That's because of the elasticity of the lungs. So you're expanding the lungs to bring air in, but the elastic fibers of the lungs, elastic fibers all around the alveoli, they're being stretched out, and kind of like a rubber band, you can stretch a rubber band out, but it takes work to keep it stretched. And then when it's time to exhale, in a resting breath anyway, so again, inhale kind of, fairly deeply, and then let it out. Letting the air out in just a sort of a resting breath doesn't actually take work. Really just the elastic recoil of the lungs pulls the volume back down and lets you breathe out, lets you exhale. So that's one important job of the elastic fibers, is it gives the lung recoil. Another important job is that it keeps alveoli open, especially during exhalation. Okay, so if you inhale, and then let's say you exhale pretty fast, and you actually push air out of your lungs, you're pushing on the lungs, you're pushing on all the alveoli, and if you're all these little tiny sacs, if you tried to design a lung and make it with little tiny sacs, one of your problems would be that the little sacs would kind of try to keep kind of collapsing on themselves. And then especially if you breathe out fast, you push on the lungs, you'd really be at a really high risk for causing those little air sacs to collapse. And if the air sacs collapse, you're not going to be able to get air in and out very effectively. So it turns out that the elastic fibers, not only do they give the lung, elastic recoil to help the lung deflate during exhalation, but also they give structure to the alveoli. They basically cause, where's my dang? Okay, there it is. They make the tissue around the alveolus kind of stiff. It's kind of like like a sponge, and the cellulose that makes up a sponge is relatively stiff, and it keeps those spaces in the sponge open. The elastic fibers in the lung do the same thing. They keep the airway, those air spaces in the alveolus open, keep it from collapsing. We'll see that. So and so there are people who have diseases like emphysema, is kind of a breakdown of the tissue of the lung, and the elastic fibers get broken down, and people with emphysema, a lot of their lung just sort of starts collapsing because there aren't enough connective tissue, especially elastic fibers, to keep those alveoli open. Okay, so again, alveoli are functionally important because they're the place where gas exchange happens. So you can see here, the air would be here. So here's a capillary, and zooming in, you can see that there's a very, very small amount of stuff between the air in the alveolus and the blood in the capillary. And so in a healthy lung, there's very little that keeps, there are very few sort of the structures that gases have to pass through in order to do the needed exchange in the lungs are very narrow and provide for maximal exchange. Let's go ahead and actually talk about, let's sort of name all the structures that are in that basically form the barrier between air in the alveolus and blood in the lungs. or blood in the capillaries. And the reason is that, again, while normally that set of structures is very narrow, disruption of any one of those can cause them to become thicker, and therefore can cause gas exchange to go down. So that whole structure altogether is called the respiratory membrane. It refers to sort of all these structures collectively. So going from alveolus to blood, let's go ahead and name the different parts. So first we get a layer of fluid here called alveolar fluid. And then we go into that squamous cell lining the alveolus, so the alveolar epithelial cell. So now would be inside that cell. This is an epithelium, so it sits on a basement membrane. That would be the next thing we encounter. There's a normally very, very narrow space underneath the alveolar cell, but before we get to the capillary. So this is what's called the interstitial space, right? So we talked about interstitial space already. It's the space between, basically, between the blood vessel and the tissue, just fluid between blood vessels and tissues. In a healthy lung, that interstitial space between an alveolus and capillary is very, very narrow. So, and then now we're arriving at the capillary. The first thing we hit is the basement membrane of the capillary endothelium. So the capillary is lined by a simple squamous epithelium. And like any epithelium, it needs a basement membrane. So here's the basement membrane for that. Right? And then we go into the endothelial cell. Have to go through that squamous cell. And then we're there, right? That's it. Now we're in the blood. Again, all those components are normally very thin, making the entire membrane altogether quite thin. But you can get disruption of one or more of these components and causing them to become thicker. Thickening of any part of those structures reduces gas exchange. And so, for example, so we talked about how people can get edema. So like if you have heart failure, so that you don't have blood flowing in, so that basically blood backs up into your veins. You get pressure in the veins increases, causing pressure in the capillaries to increase. That can make water leak out of the capillary into the interstitial space. And that condition is called pulmonary edema. You basically get thickening of the interstitial space. And you can actually get increased alveolar fluid. So alveolar fluid can go up, interstitial space can go up, thereby making the respiratory membrane quite a bit thicker than normal. And when that happens, you get a lot lower gas exchange than you normally do. So people who have bad pulmonary edema, they essentially you see them start gasping for breath because they're getting air into their lungs and their alveoli okay, but they have more fluid here, more interstitial fluid, and a lot less gas exchange, and so they're just not exchanging gas as well, and so they're basically asphyxiating due to thickening of the respiratory membrane. Okay, that will do it for this lecture.